Welcome to the deep dive. We know you want to grasp complex topics quickly and deeply without feeling totally swamped.
Yeah, cutting through the noise is key.
So today we're doing something a bit different. We're dedicating the next couple of hours to a really focused MCQ multiple choice question revision session all about healthcare quality.
Right. Think of it as a guided tour through the essential knowledge. We've pulled together questions covering a really wide range: principles, measurement, safety, operations. The works.
The idea isn't just rote memorization, obviously. It's about digging into why the right answers are right, pulling out those core concepts you really need to understand.
Exactly. And you'll see how interconnected it all is. The same quality ideas pop up everywhere. It's designed to help you see those connections.
Okay, let's get started. First theme, quality improvement principles and practices. We'll kick off with question 21. It asks, from a quality improvement perspective, the most desirable state is when? And the options are things like identifying best practices, achieving consensus, having clinical studies, or multiple treatment options. What's the ideal here?
Well, that's a good starting point. While all those things are good, from a pure QI perspective, the most desirable state is definitely A. Best practices have been identified.
Why is that the top goal?
Because it gives you something concrete.
Yeah.
It moves beyond just talking about quality to saying, okay, this is the standard based on evidence that leads to better outcomes. It's the benchmark you aim for.
Right, it provides that clear target. Okay, next up, question 27. This one asks about essential components for an effective QI project, but it wants the exception. The options are A, hospital CEO, CFO involvement, B, senior admin support resources, C, clear purpose, D, timeline reporting structure. Which one isn't always essential?
This requires a bit of nuance. You absolutely need senior admin support, a clear purpose, and a timeline. Those are non-negotiable.
Okay.
But direct hands-on involvement from the CEO and CFO in every single QI project, probably not essential. Their high-level backing, yes, but day-to-day involvement, that's likely the exception. So A.
That makes sense. You need the blessing from the top, but maybe not their presence in every meeting. Okay, question 42. This is a classic. The PDCA cycle. Can you just quickly remind us what that stands for?
Sure. PDCA is fundamental. It's plan, do, check, act. Plan the change, do it usually on a small scale, check the results, and act on what you learned, either adopt, adapt, or abandon the plan.
That's iterative cycle, right? Always learning and refining.
Exactly. It embodies continuous improvement.
Now, building on that, question 88 mentions the FOSIUS model. How does that relate to PDCA? What does FOSIUS stand for?
FOSIUS is often used, especially in healthcare, before you get deep into the PDCA cycle. It helps structure the initial phase. It's find a process, organize a team, clarify the current process, understand the variation, and select the improvement strategy.
Ah, okay. So FOCUS helps you zero in on the problem and understand it before you start planning the solution with PDCA.
Precisely. It sets the stage for effective planning.
Okay, let's think bigger picture. Question 155 asks about the difference between traditional quality assurance, QA, and quality improvement, QI. What's the core difference?
This is a really key evolution. Traditional QA was often retrospective, looking for errors, inspecting, and often focusing on individual performance, sometimes assigning blame.
Right, the old find the bad apple approach.
Kind of, yeah. QI, on the other hand, is proactive. It looks at the process and assumes most problems stem from the system, not just individuals. The goal is to improve the system to prevent errors in the first place. It's about building better processes for everyone.
That's a huge cultural shift, moving from blame to system improvement.
Absolutely essential.
Now, question 295 looks at total quality management, TQM, and its impact. It asks, what is not a typical impact? Options include diminishing top management's role, emphasis on customers, reducing hierarchy, and individual involvement. What doesn't fit?
Well, TQM actually requires strong top management commitment and involvement. They need to lead the charge. So diminishing top management role is definitely not an impact of TQM. It usually enhances their role in driving quality.
So the leadership has to be visibly championing it.
Absolutely. Without that, it often fails.
Okay, last one in this section. Question 332. Simple but critical. Who is responsible for quality improvement in an organization?
Easy one, but so important. It's everyone. Quality isn't just one department's job. It's embedded in everyone's role, from the front line to the C-suite.
A shared responsibility. Got it. Okay, let's pivot to our next theme, quality measurement and data analysis. How we actually track and understand quality. Question 22 gives an example. Selecting every fifth patient record for a PCI procedure. What kind of sampling is that?
That method, where you pick every nth item, is called systematic sampling.
Straightforward enough.
Yeah.
Now, Question 25 asks about meaningful quality process measures. What two characteristics must they have?
For a measure to be truly useful, it needs to be, one, relevant. It actually has to relate directly to the process you care about. And two, valid. It has to accurately measure what you think it's measuring.
Relevant and valid. Makes sense. If it's irrelevant or measured poorly, the data is useless.
Pretty much, yeah. Garbage in, garbage out.
Okay, data visualization. Question 29. You're running a vaccination clinic and want to show the age distribution of patients. What's the best chart type? Pie chart, radar, Gantt, or scatter plot?
To show parts of a whole, like proportions of different age groups, a pie chart is usually the most intuitive visual.
Yeah, you can quickly see the slices. Now, analyzing data over time. Question 35 talks about a run chart showing treatment delays. What pattern indicates a true statistical increase?
On a run chart, you're looking for non-random patterns. One key signal of a statistically significant shift, like an increase, is 8 consecutive data points all going up, ascending.
8 in a row. That's the magic number to say, okay, something's likely changed here.
It's one of the standard rules, yes. It suggests it's unlikely to be just random fluctuation.
Building on that, question 43 describes a time sequence chart with the center line and statistical control limits. What's that called?
Ah, that's a control chart. A very powerful tool in QI.
And what does it help us do?
It helps distinguish between normal expected variation within a process, what we call common cause variation, and unusual variation caused by specific events or changes special cause variation. It tells you if your process is stable or out of control.
So it helps us know when to react to a change versus when it's just background noise.
Exactly. Prevents overreacting or underreacting.
Okay. Question 99. What happens to the standard error of the mean if you increase your sample size?
Standard error reflects the uncertainty in your estimate of the mean. More data means less uncertainty, so as sample size increases, the standard error decreases.
More data, more confidence, smaller error. Got it.
Yep.
Let's revisit basics. Question 141 asks for the 3 main measures of central tendency.
That would be the mean, the average, the median, the middle value when data is sorted, and the mode, the most frequent value.
Mean, median, mode. Each tells you something slightly different about the center of your data.
Right. The mean is sensitive to outliers, the median isn't, and the mode tells you the most common result.
Okay. Now, question 185 wants a definition of standard deviation. In simple terms.
Standard deviation measures the spread or dispersion of data. Think of it as the average distance of each data point from the mean. A low standard deviation means data points are clustered close to the average. A high one means they're spread out.
So it quantifies variability or consistency.
Precisely.
Question 193 talks about percentiles. If a patient's length of stay is at the 90th percentile, what does that mean?
It means that 90% of all other patients had a length of stay equal to or less than that patient's stay. Or, put another way, their stay was longer than 90% of the others. It shows relative position.
Okay, it places them within the distribution. Question 222 describes listing all the values in a dataset and how often each occurs. What's this basic data organization method called?
That's just a simple frequency distribution, fundamental step in summarizing data.
And question 247 asks again, what's the most common measure used to describe variability?
We just talked about it. It's the standard deviation. It's really the workhorse statistic for describing spread.
Okay. And finally for this section, question 289. You have data with a very wide range. What's the best way to rank order it without listing every single value?
When the range is wide, listing every value gets cumbersome. The better approach is a grouped frequency distribution. You create intervals or bins like ages 0, 10, 11, 20, etc., and count how many fall into each group.
So you group the data to make it more manageable and see the pattern.
Exactly. It summarizes effectively.
All right, we've covered measurement and analysis. Now let's move to a really critical area, patient safety. Question 26 starts with a definition. What is iatrogenic illness?
Iatrogenic illness is, unfortunately, illness caused by medical examination or treatment. It's harm resulting from healthcare itself.
A sobering reminder of, first, do no harm. Okay, question 33 looks at fall prevention programs. It asks for the exception among these components. Assessment criteria, evidence-based risk tool, reimbursement criteria, post-fall assessment.
The core parts of the program are assessing risk, using tools, and handling falls if they happen. Reimbursement criteria, while important for funding, aren't an intrinsic part of the clinical program design itself, so C is the exception.
Right, reimbursement influences it but isn't in it. Question 62 asks for an example of a never event or sentinel event. Which one fits? Missed antibiotic dose, minor fall bruise, mild transfusion fever, or patient suicide in a psychiatric ward?
A never event is something serious and largely preventable that just shouldn't happen. Of those options, patient suicide in a psychiatric ward fits the definition of a sentinel event most clearly due to its severity.
These are the events that trigger immediate, deep investigation.
Absolutely. Red alerts.
Question 89. What's the best way to implement national patient safety goals to minimize errors, focusing on the patient?
The most effective way involves actively engaging the patient and family. So it's about giving clear written and verbal instructions and encouraging them to ask questions, making them partners in safety.
Empowering the patient. Makes sense. Question 102 presents a scenario. A patient suicide using a belt in a psychiatric unit. What's an immediate, appropriate policy change?
Given that specific mechanism, the most direct preventative policy would be allowing no belts to be brought into the unit, removing the specific means used.
A direct response to the identified risk. Now, question 137 refers to the landmark 1999 IOM report, "To err is human." What was a key, startling finding?
That report really shook things up. A major finding was the estimate of potentially upwards of 90,000 preventable patient injuries or deaths occurring annually in U.S. hospitals due to errors. It highlighted the scale of the problem.
Really put safety on the map. Question 138 then asks about obstacles to building a safety culture. Which of these is not an obstacle? Blaming individuals, staff complacency, unsupportive leadership, or accountability on healthcare systems?
Blame, complacency, lack of leadership support, those are definitely obstacles. But placing accountability on healthcare systems is actually part of building a strong safety culture. It's about system responsibility, not just individual fault. So D is the exception. It's actually necessary.
Right. System accountability is the goal, not an obstacle. Okay. Question 166. Monitoring medication administration to minimize errors. What category does that fall under? Risk management, QM, or financial?
That's squarely in the realm of quality management, QM. It's about improving the quality and safety of that specific clinical process.
Okay. Question 170 asks about negative outcomes of a patient fall, but wants the exception. Options are injury death, automatic copay increase, increased fear, decreased social interaction.
Falls can cause injury, fear, and reduced mobility, leading to social isolation. An automatic increase in the patient's copay to Medicare/Medicaid is not a direct clinical or psychosocial outcome of the fall itself. It's a financial insurance issue. So B is the exception.
Got it. Question 173. A nurse takes a verbal med order over the phone. What's the safest procedure?
The gold standard is read back and confirm. The nurse should repeat the complete order back to the prescriber and get explicit confirmation before giving the med. Closed-loop communication.
Critical step to catch misunderstandings. Question 174 asks about essential elements of a good fall prevention policy. What needs to be included?
A comprehensive policy needs a few key things. A standardized assessment process for risk, defined interventions based on risk level, clear guidance on the frequency of reassessment, and procedures for post-fall assessment and follow-up.
Assessment, intervention, reassessment, and post-fall management covers the whole cycle.
Right.
Question 204, who's typically accountable for ensuring timely prophylactic antibiotics before surgery?
That responsibility often falls specifically to the holding room nurse, who manages the patient immediately before they enter the OR.
Okay. Question 240 asks for the most effective overall approach to ensuring patient safety. What are the key principles?
It's really a combination. You need to focus on improving processes, definitely minimize blame, and foster a just culture, and have strong, visible leadership commitment driving it all.
Process, culture, leadership, the trifecta.
You could say that, yeah.
Question 293. What are the essential practices to minimize post-surgical infections?
Several critical things. Timely prophylactic antibiotics, rigorous hand hygiene, correct site marking, and performing the pre-procedure timeout verification.
All crucial layers of defense. And question 309 asks specifically, when is that timeout taken?
It has to be immediately before the operation starts, literally, right before the incision is made.
Final check. Okay, question 323. What's one highly effective strategy to reduce medication errors?
There are many, but adopting double-checking routines, having a second person verify critical steps like dose calculations or high-alert meds, is a very effective way to catch errors.
That second pair of eyes makes sense. And finally, for safety, question 327, a patient dies due to a known medication interaction. What's the most critical organizational action?
In such a serious event, the essential step is to conduct a thorough root cause analysis, RCA. You have to dig deep to understand the system failures that allow the interaction to happen and lead to harm, so you can prevent it from recurring.
Find the system flaws, not just the immediate cause. Okay. That covers patient safety. Let's shift now into healthcare operations and management, the nuts and bolts of running things. Question 24. A hospital compares its length of stay, LOS, and readmission rates to benchmarks. Both are higher than desired. What's the likely next step?
Well, you've identified two problems. You'd likely need to investigate both, but often high LOS can contribute to other issues. So a reasonable next step would be to dig deeper into the reasons for the longer length of stay. What's causing the delays?
Makes sense. Tackle the potential upstream issue first. Okay, question 38 asks about the operations management transformation process in a hospital context. What kind of transformation is primary? Physiological, informational, psychological, or locational?
Hospitals are primarily transforming the patient's health state, so the core transformation process is physiological.
Okay. Question 48. Who's responsible for notifying clinical engineering when new medical equipment arrives?
This is often a decentralized responsibility. Typically, each department that receives new equipment is responsible for notifying clinical engineering so it can be checked, tagged, and entered into the inventory system.
So the receiving department owns that step. Question 54. When should the process of collecting a patient's personal, demographic, and insurance info ideally occur? During admission, pre-admission, discharge, or post-discharge?
To streamline the process and avoid delays on the day of service, collecting this information should happen during pre-admission whenever possible.
Get it done beforehand. Good practice. Question 55 asks about the primary use of clinical pathways and guidelines in hospitals.
The main purpose is to minimize unnecessary variation in patient care for specific conditions by outlining evidence-based steps. This promotes consistency and efficiency.
Standardized care based on best practices. Got it. Question 72, a classic safety acronym. RACE for fire safety. What does it stand for?
RACE is crucial for fire response. Remove anyone in immediate danger, activate the alarm alert system, contain the fire by closing doors, and extinguish the fire if safe to do so, or evacuate.
Remove, activate, contain, extinguish, evacuate. Good one to know. Question 114 looks at the revenue cycle and asks which statement is not true. The options relate to when it starts, who's involved, etc. The incorrect statement is likely the revenue cycle only begins after a diagnosis and treatment plan are established.
Right, that's not true. The revenue cycle starts much earlier, really, with scheduling and pre-registration, gathering that insurance info we just talked about. So the statement that it only begins after diagnosed treatment is false.
It starts way up front. Now, question 120 asks what is not typically considered part of the front end of the revenue cycle. Options include scheduling, insurance verification, medical records, and financial counseling.
Scheduling, insurance verification, financial counseling, those are all definitely front-end activities. Medical records management, while crucial overall, is more of a middle or ongoing process supporting clinical care and coding, not strictly a front-end initiation step of the revenue cycle itself.
Okay, so medical records is the outlier there. Question 140 asks for a true statement about the back end of the revenue cycle. It mentions it's jointly held by finance, compliance, audit, and IS.
That sounds true. The back end, dealing with billing, collections, denial management, requires coordination between finance, compliance for regulations, internal audit for controls, and information systems for the billing tech.
It's a team effort back there. Question 148 asks, who is not considered a customer in the patient scheduling process? Options: patient, physician office, insurance company, hospital admitting staff.
The patient, the physician's office referring the patient, and even the hospital's own admitting staff are all direct customers or users of the scheduling process. The insurance company, while impacted by scheduling outcomes, isn't typically considered a direct customer of the scheduling function itself.
Interesting distinction. Okay. Question 152 looks at the pharmacy's role in revenue cycle management and asks what is not typically among their roles. Options involve formulary management, charge capture, selection of date of service, and medication use review.
Pharmacy plays a huge role in managing drug costs, formulary, ensuring charges are captured correctly, and reviewing medication use for appropriateness. However, the selection of the date of service is generally determined by when the service is actually provided and documented, not selected by the pharmacy as part of their revenue cycle function.
Date of service is usually driven by the encounter itself. Question 165 asks, what factor has NO role in determining the markup cost on pharmaceuticals charged to patients' insurers? Options: acquisition cost, administrative costs, desired profit, current Medicare/Medicaid rates.
Hospitals consider their purchase cost, overhead, and profit margin when setting charges.
Mhm.
However, current Medicare and Medicaid reimbursement rates dictate what those specific payers will pay, not how the hospital sets its initial charges or markup. So D is the factor that doesn't determine the markup itself.
What Medicare pays is different from the hospital's list price strategy. Got it. Question 172 asks about direct costs and a hospital financial analysis, which is not usually a direct cost. Nursing salaries, medical supplies, facility maintenance, prescription drugs.
Direct costs are those directly tied to providing patient care, like staff salaries for that unit, supplies used for patients, drugs administered. Facility maintenance, like fixing the roof or HVAC system, is typically considered an indirect cost or overhead allocated across departments rather than tied to a specific patient service.
Maintenance is overhead, not direct patient care cost. Okay. Question 190/10 asks for the principal purpose of a management information system, MIS, in healthcare.
The fundamental purpose of an MIS is to collect, process, and present information in a way that supports management decisions.
Data for decision-making. Question 223 identifies 3 essential entities comprising the hospital manpower structure. What are they?
The 3 core pillars are typically the governing body, like the Board of Trustees, the administration or management team, CEO and other executives, and the medical staff, physicians and other licensed independent practitioners.
Governing body, administration, medical staff, the key groups. Question 277 asks for the term used to categorize patients based on volume and severity to determine nursing care requirements.
That categorization system is known as acuity. Higher acuity means more intense nursing care needs.
Acuity levels. Okay. And question 325 asks for the best description of utilization management in healthcare.
Utilization management is fundamentally about ensuring the best, most appropriate allocation of healthcare resources. It focuses on medical necessity, appropriateness of care level, and efficiency.
Making sure resources are used wisely and appropriately. All right, that wraps up operations and management. Let's move into leadership and organizational culture. Question 34 presents a scenario. 2 hospitals merge. One successfully transitions to new values, the other struggles. What's the likely reason for this successful transition?
Successful cultural transitions, especially during mergers, usually hinge on ensuring adoption by all staff, not just management. Getting buy-in and participation at every level is critical for making new values stick.
It has to permeate the whole organization. Question 44 asks for the best way to establish patient safety as an ongoing, embedded part of the culture.
To truly embed it, you need to make it part of the fabric of everyone's job. So making safety responsibilities part of job descriptions and performance evaluations is a powerful way to signal its ongoing importance.
Build it into the structure. Question 46 asks for the best way to facilitate change within an organization.
People support what they help create. The best way to facilitate change is usually to involve the individuals who will be directly affected by the change in the planning and implementation process.
Get them involved early and often. Question 50. Who is the overall coordinator responsible for strategic planning in a hospital?
While many are involved, the ultimate responsibility for coordinating and overseeing the strategic planning process typically rests with the Chief Executive Officer's CEO.
The buck stops there for strategy. Question 52. How can healthcare quality professionals best communicate organizational values?
Actions speak louder than words. The most effective way is by leading by example, consistently demonstrating those values in their own work and interactions.
Walk the talk. Question 57 describes managers who assume employees enjoy work, are self-motivated, and seek responsibility. What management theory is this? X or Y?
That optimistic view of employees aligns with McGregor's theory Y. Theory X is the more pessimistic view that assumes employees dislike work and need close supervision.
Theory Y assumes people want to contribute. Okay. Question 61 suggests one of the greatest motivators for employees is what?
Research often points to autonomy, having control over one's work, and how it's done as a very powerful motivator.
Giving people ownership. Question 77. Management by quality improvement principles places the primary emphasis on what?
QI is fundamentally customer-focused. So the emphasis is squarely on understanding and meeting customers' expectations. Patients being primary customers, but others too.
Focus on the customer. Question 78 describes a leader who makes decisions independently and strictly enforces rules. What leadership style is that?
That sounds like a classic autocratic leadership style.
Mm.
Directive, top-down control.
Okay. Question 79 asks for the best description of an organization's vision statement.
A vision statement should reflect the organization's future aspirations, where it wants to go, what it wants to become. It's forward-looking and inspirational.
the desired future state. And question 81 asks what a hospital mission statement should include.
A mission statement defines the organization's purpose and reason for being now. For a hospital, it should absolutely include a commitment to serve the community.
Mission is purpose, vision is future. Got it. Question 127 talks about staff accountability. What necessary balance is needed?
For accountability to be fair and effective, staff need to have both responsibility for tasks and the commensurate authority to carry them out. You can't hold someone accountable if they don't have the power to act.
Responsibility must come with authority. Makes sense. Question 168 asks about the key factor for the long-term success of a patient safety program.
For sustainability, it can't be just one department's initiative. Long-term success requires involving the entire organization, making safety everyone's business.
Broad engagement again. Question 181 looks at cultural change for continuous quality improvement, CQI. What must administration believe for this to happen?
Fundamentally, leadership needs to believe that the benefits of CQI justify the costs and effort involved. They need to see the value proposition.
See the ROI, essentially. Question 186 asks for the first step to facilitate change in an organization.
Before you can change things, you need to know what needs changing. So the first step is usually to identify the problems or opportunities for improvement.
Define the problem first. Question 224 asks what leadership style is often best for motivating employees and optimizing change.
While different styles fit different situations, a participatory or collaborative style where leaders involve employees in decision-making is often very effective for motivation and navigating change.
Involving people, again. Question 227. How does a quality professional best facilitate a quality culture?
A good starting point is assessing the organization's readiness to commit to quality, understanding the current culture, identifying barriers and enablers before launching major initiatives.
Gauge the readiness first.
Yeah.
Okay. Question 265 identifies crucial elements for successfully implementing QI activities.
Two things consistently rise to the top: leadership commitment and organization-wide collaboration. You need support from the top and teamwork across departments.
Leadership and collaboration. Key themes. Question 268 asks about the purpose of an organization-wide quality council.
A quality council, typically composed of senior leaders and managers, acts as a leadership control group or steering committee for the organization's overall quality strategy and initiatives.
The steering committee for quality. Question 278 asks what an organization's mission statement describes.
As we touched on, the mission statement describes the organization's fundamental purpose, why it exists.
Its reason for being. Question 337. A facilitator is starting work with a new team. What's the best way to begin?
Get organized. A good first step is to set the meeting agenda and establish priorities for the team's work. Provide structure and direction from the outset.
Set the ground rules and agenda. And question 338 mentions the typical stages of team growth. Can you list them?
Tuckman stages, they are. Forming, coming together, storming, conflict arises, norming, resolving conflicts, setting norms, performing, working effectively, and sometimes adjourning when the team disbands.
Forming, storming, norming, performing, adjourning. The classic team life cycle. Okay, that's leadership and culture. Let's move to tools and techniques for quality improvement. Question 32 asks about evaluating long waiting times, considering factors like staffing, methods, measures, materials, equipment. What tool is good for exploring all these potential causes?
That sounds like a perfect application for a cause and effect diagram, also known as an Ishikawa diagram or fishbone diagram. It helps categorize potential causes under those kinds of headings.
The fishbone diagram. Great for brainstorming causes. Question 39 asks who developed bar chart techniques for project management.
That would be Henry Gantt, hence the Gantt chart.
The Gantt chart. Okay. Question 59 asks for the most effective tool to improve communication between caregivers, especially during handoffs.
The widely adopted and recommended tool for structured communication, particularly in handoffs, is SBAR.
SBAR. Remind us.
Situation, Background, Assessment, Recommendation. Provides a clear, concise structure for sharing critical patient information.
Situation, background, assessment, recommendation. Very useful. Question 69 asks about the purpose of a Gantt chart.
A Gantt chart is a project management tool that visually relates interdependent activities to their required completion time. It shows tasks, timelines, and dependencies.
Visualizing the project schedule. Question 82 introduces failure mode and effects analysis, FMEA. What kind of process is it?
FMEA is a proactive process, used before something goes wrong to systematically identify potential failure points in a process, assess their likely impact effects, and figure out how to prevent them.
Proactive risk assessment. Good. Question 94 describes a picture of the process mapping out each individual step. What's that?
That's a flowchart, a visual representation of the steps in a process sequence.
Basic but essential tool. Question 104 mentions a tool used to relate the interaction between equipment, methods, personnel, instead of customers here likely meant personnel or environment, and materials on an outcome.
That again points towards a cause and effect diagram, Ishikawa fishbone. It explicitly looks at how those different categories influence an outcome or problem.
Fishbone again. Versatile tool. Question 107 asks about a group decision-making technique specifically for generating creative ideas.
The classic technique for generating a large volume of creative ideas without initial criticism is brainstorming.
Get all the ideas out there first. Question 119 asks again about a graphic tool to explore all factors influencing an outcome.
Repetition reinforces. It's the Ishikawa diagram, or cause and effect diagram again. Clearly a key tool for root cause exploration.
Okay, seems important. Question 149. You're developing a performance improvement action plan. What tool should you use first to understand the problem?
Before you create an action plan, you need to understand the root causes of the problem. So using a cause and effect diagram first to identify those potential causes is a logical starting point.
Understand why before deciding what to do. Question 177 asks about the use of P-control charts. What do they help measure or determine?
P-charts are a type of control chart used for attribute data, specifically proportions or percentages, like infection rates. They help measure the stability of that proportion over time, compare performance to a threshold, and determine if variation is common cause or special cause.
For tracking percentages over time. Got it. Question 303. You're starting a root cause analysis, RCA. What's often the very first tool you'd use?
To understand what happened in an RCA, you first need to clearly map out the sequence of events as they occurred. So a flowchart is usually the first step to establish the timeline and process flow.
Map out what actually happened. And question 308 asks about a tool to determine the relationship between two different sets of data or variables.
To see if there's a correlation or relationship between two variables like dose of a drug and blood pressure change, you'd use a scatter diagram. It plots pairs of data points to visualize the relationship.
A scatter diagram for correlation. Okay, that's a good overview of tools. Now let's look at external factors and regulations. Question 36 asks about the two major responsibilities of the FDA regarding drugs and devices.
The FDA is primarily concerned with ensuring the safety and effectiveness of drugs and medical devices before they reach the public.
Safety and effectiveness, core FDA mandate. Question 41 asks, what is not typically associated with the Malcolm Baldrige National Quality Award? Options include a framework for excellence, site visits, inexpensive consulting.
The Baldrige Award provides a framework, involves rigorous assessments including site visits for finalists, and recognizes role models. It is not, however, an inexpensive consulting service. The application process itself is demanding.
It's an award framework, not cheap consulting. Question 58 mentions some applications of ICD code information, diagnostic codes. What are they used for?
ICD codes are used for many things, including billing and reimbursement, but also supporting clinical coding initiatives, health services research, and quality reporting like HEDIS measures.
Billing, research, quality reporting, versatile codes. Question 63 asks about an NCQA review area that assesses preventative services and continuity of care. What area is that?
NCQA, National Committee for Quality Assurance, accreditation for health plans, includes reviews of quality assurance and improvement, which heavily features assessment of preventive services, chronic care management, and continuity.
Quality assurance covers those aspects. Question 66. Besides the label on a hazardous chemical container, what other important documents should you read?
You should always consult the Material Safety Data Sheet, MSDS, now often called Safety Data Sheet, SDS. It provides detailed information about the chemicals, hazards, handling, and emergency measures.
MSDS SDS for the details. Question 70 asks what Baldrige Award guidelines are not typically used for. Options relate to improving processes, results, customer focus, and specifically computer systems.
While improving overall systems is part of Baldrige, the guidelines aren't specifically designed as a tool just to improve computer-based information systems. Their focus is much broader on overall organizational performance excellence.
It's about the whole organization, not just IT. Question 91. When Joint Commission surveyors visit a hospital, what's a primary thing they review?
Surveyors spend a significant amount of time reviewing medical records to assess compliance with standards related to documentation, care processes, patient rights, and safety. They trace patient care through the record.
The record tells a story. Question 108 asks which category is not eligible for the Baldrige Award, according to the options provided. Healthcare, education, nonprofit, business. Self-correction. The original outline notes this option might be incorrect based on general knowledge, but sticking to the source's implied answer.
Based strictly on the common historical categories presented in some older contexts or specific test questions. Sometimes nonprofit companies were listed as a separate category or implied exclusion, although Baldrige eligibility has evolved. However, it's important to note that currently, nonprofits are eligible, but if forced to choose based on potentially outdated test material, that might be the intended answer.
Okay, acknowledging that nuance based on the source material provided. Let's move to question 134. An organization's safety program must include all except D. Options include hazard surveillance, safety policies, employee education, monthly safety committee meetings, self-correction. Again, the outline notes potential inaccuracy.
Hazard surveillance, policies, and education are fundamental. While safety committee meetings are common and often recommended, mandating them specifically as monthly might be the exception here, depending on the specific regulatory context. The frequency isn't always rigidly defined as monthly for all programs, though regular meetings are key. So D might be the intended exception.
The specific frequency might be the intended exception. Question 261 asks about the nature of the accreditation process in healthcare, like Joint Commission. Is it mandatory, voluntary, governmental, or punitive?
Generally speaking, accreditation by bodies like the Joint Commission is voluntary. While often necessary for reimbursement or state licensure, making it quasi-mandatory in practice, the process itself is initiated voluntarily by the healthcare organization.
Technically voluntary, but practically essential. Question 282. What does the credibility of the accreditation process mostly depend on?
The credibility hinges on the fact that it's conducted by external peer reviewers professionals from similar organizations evaluating standards. This objectivity is key.
Peer review lends credibility. Question 315 asks which institution or agency introduced the concept of core measures for hospital quality reporting?
The initial push for standardized core measures came primarily from the Joint Commission, in collaboration with CMS, Centers for Medicare and Medicaid Services.
Joint Commission and CMS drove core measures.
Okay.
And question 316. What's the first step an organization should take if it wants to apply for an external quality award like Baldrige?
The very first step is internal assessment. You need to review your current practices against the award's standards criteria to understand your strengths, weaknesses, and readiness.
Self-assessment against the criteria first. Good. That covers external factors. Let's touch on economic considerations. Question 37 asks about the best economic evaluation method when both costs and consequences can be measured in monetary terms.
When you can put a dollar value on both the costs and the benefits, consequences, the most direct method is cost-benefit analysis, CBA.
Cost-benefit when everything is monetized. Question 49 lists 4 kinds of cost behaviors in cost accounting. What are they?
The basic types are fixed costs, don't change with volume; variable costs, change directly with volume; semi-variable, part fixed, part variable; and semi-fixed, fixed within a range, then jump.
Fixed, variable, semi-fixed. Okay. Question 64 asks for a definition of cost-effectiveness.
Cost-effectiveness analysis compares interventions based on their costs and their outcomes measured in natural units, like years of life gained, cases cured. It's about finding the option that delivers the most health outcome per dollar spent. The option mentioned in quantitative in consideration hints at this comparison of cost to non-monetary units of effect.
Comparing costs to health outcomes. Question 74 presents a scenario. A private insurer has contracts with 2 hospitals offering the same service, but one has lower costs. What's their likely best option?
From a purely cost perspective, the insurer would likely try to negotiate an exclusive contract with the lower cost center, or at least steer patients towards it to save money.
Drive volume to the cheaper option. Question 75 asks for one method an organization can use to transfer risk.
The most common way organizations transfer financial risk is by purchasing commercial insurance.
Insurance transfers the risk. Question 76 asks about a factor critical to capital decision-making, like buying expensive equipment.
Major capital decisions shouldn't happen in a vacuum. They need to align with the organization's long-term goals. So strategic planning activities are critical context for making those big investments.
Align capital spending with strategy. Question 133 asks what type of budget typically allocates funds for major equipment purchases.
Large, long-term asset purchases like major equipment are funded through the capital budget, separate from the operating budget for day-to-day expenses.
Capital budget for big-ticket items. Question 147 describes a departmental budget where all cost centers are reevaluated from scratch each budget period. What's that called?
That approach, where you have to justify every dollar every time rather than just adjusting last year's budget, is called zero-based budgeting.
Start from zero each time. Question 160 relates to lean principles. What determines value in a lean process?
In lean thinking, value is always defined from the perspective of the customer. Any activity that doesn't add value for the customer is considered waste.
Value is defined by the customer. Question 179 asks how large quality data sets are generally summarized.
When dealing with large data sets, you typically start by summarizing them, using descriptive statistics, things like mean, median, mode, standard deviation, frequencies, to get an overview of the data's characteristics.
Use descriptive stats to simplify large data sets. Question 199 asks about the most cost-effective process for preventing unnecessary resource consumption before a patient is admitted.
Preventing unnecessary admissions or ensuring patients are placed in the right level of care from the start saves resources. So, effective pre-admission screening, reviewing appropriateness before admission, is highly cost-effective.
Screen effectively beforehand. Question 302 refers to a chart not shown, but typically a break-even chart, and asks what point B usually represents.
On a standard break-even chart, the point where the total revenue line crosses the total cost line, point B typically, represents the break-even point where the organization is neither making a profit nor a loss.
Where costs equal revenue. Question 306 involves a calculation, details omitted, about how many patients are needed to maintain a profit rate for a new project. This involves break-even analysis concepts.
Right, that calculation would use principles of cost-volume-profit analysis to determine the volume needed to achieve a target profit, considering fixed costs, variable costs per patient, and revenue per patient.
A CVP calculation. Okay. Let's move to human factors and communication. Question 260 asks about common barriers to effective communication.
Many things get in the way, but common barriers include making assumptions about what the other person knows or means and making judgments instead of actively listening.
Assumptions and judgments, big barriers. Question 271 asks what enhances effective communication.
One key element is attending, truly focusing on the speaker, showing you're listening through verbal and nonverbal cues. Being present.
Paying attention. Question 291. There's doubtful trust between administration and employees. What's the best way to conduct a survey to get honest feedback?
To encourage honesty when trust is low, anonymity is crucial. A traditional anonymous paper and pencil survey might be perceived as more secure than an online one in such a situation.
Anonymous paper might feel safer. Question 326 asks again about the purpose of the SBAR tool.
As we discussed, SBAR's primary purpose is improving communication between caregivers, providing that structured format for critical information exchange.
Structured communication. And question 339. Patient satisfaction benchmarks for waiting room ambiance aren't being met. What are reasonable first actions?
You could address the environment directly, maybe add magazines or calming music, but it's also crucial to look at staff interactions. Perhaps monitor staff conversations near the waiting area to ensure they are professional and not contributing negatively to the atmosphere.
Improve the environment and check staff interactions. Okay, we're nearing the end, focusing now on specific healthcare areas and more performance improvement initiatives. Question 23 looks at national quality measures for AMI, heart attack, and asks for the exception. Options relate to aspirin, beta blockers, smoking cessation, long-term lipid therapy adherence.
Core measures for AMI typically focus on treatments given during or immediately after the hospital stay. Aspirin, beta blocker, cessation advice. While long-term lipid therapy is vital, tracking long-term adherence months or years later is usually outside the scope of the initial hospital core measures, so D might be the exception.
Focus on the acute phase for core measures. Question 100 asks for the definition of a nosocomial infection.
A nosocomial infection, now more commonly called a healthcare-associated infection, HAI, is an infection acquired while receiving care in a healthcare setting.
Got it in the hospital. Question 103 asks about the level of measurement for data representing feelings toward quality of provided care. AG, very satisfied, satisfied, neutral, dissatisfied.
When data represents categories that have a natural order or ranking, but the intervals between them aren't necessarily equal, that's ordinal level measurement.
Ordered categories. Question 116 asks for the essential functions of an infection control program.
The two core functions are surveillance, tracking infections, and prevention, implementing measures to stop them.
Track and prevent. Question 123 asks during which phase of the medication process the majority of medication errors occur. Prescribing, transcribing, dispensing, or administration.
Studies consistently show that the prescribing phase is where the largest proportion of medication errors originate, although errors can happen at any stage.
Errors often start at prescribing. Question 144 asks which type of monitor provides patient outcome information. Options might include process measures, but the answer here is likely related to infection rates.
Right. Measures like the hospital nosocomial infection rate directly reflect a patient outcome, whether they developed an infection as a result of their care.
Infection rate is an outcome measure. Question 163 asks for the concept of a medical home.
The patient-centered medical home, PCMH model, emphasizes having an ongoing source of primary care that coordinates all the patient's healthcare services across different settings.
Coordinated primary care. Question 196 asks which national patient safety goal is applicable to essentially everyone involved in patient care. It refers to Goal 2.
Goal 2, historically focused on improving the effectiveness of communication among caregivers, something relevant to absolutely everyone.
Communication applies to all. Question 201 asks for correctly aligned statements with the disease management DM concept.
Disease management programs focus on proactively managing care for patients with chronic conditions, often involving patient education, regular monitoring, and coordinating care to improve outcomes and reduce costs for specific diseases like diabetes or heart failure.
Proactive chronic care coordination. Question 207 mentions a unique challenge in identifying quality measures specifically for children's health care.
A key challenge is the sheer diversity of diagnoses and developmental stages across different age groups in pediatrics, making it harder to find single measures that apply broadly compared to adult care.
Kids change fast, different needs at different ages. Question 217. What's the best way to achieve full compliance with discontinuing postoperative antibiotics within the recommended time frame? For example, 24 hours.
Relying on reminders can fail. The most reliable way is often through system changes, like implementing an automatic stop order in the pharmacy or CPOE system that discontinues the antibiotic after the specified duration unless actively renewed by the physician.
Build it into the system, automatic stop orders. Question 219 asks for an example of sets of discrete variables.
Discrete variables are countable, distinct values. An example would be patient discharges in March compared to May. You can count the exact number of discharges each month. Continuous variables, like blood pressure, can take on any value within a range.
Countable numbers. Question 292 asks for a priority area for investigation in an OB/GYN department's quality review.
Given the potential severity, post-delivery septicemias, severe infections after childbirth, would likely be a high priority area for review and prevention efforts.
Serious infections need focus. Question 311. A diabetes education study uses a pre-test survey. What's its purpose?
The purpose of a pretest is to obtain baseline data on the participant's knowledge or status before the intervention, the education program, begins. This allows you to measure the change or impact of the program by comparing pre-test and post-test results.
Establish the starting point. Question 318 provides a statement. Infection rate after a cesarean section shall be no more than 5%. What does the statement define?
That specific measurable level of performance, no more than 5%, defines a standard of care or a performance target.
A target standard. Question 335 asks for an example of positive patient-related outcomes in a radiology department.
An outcome measure reflects the result of care. In radiology, ensuring that radiology reports matched with pathology reports, when applicable, would be an indicator of diagnostic accuracy, a positive outcome. Process measures might be report turnaround time.
Diagnostic accuracy is an outcome. Okay, now some more performance improvement questions. Question 51. After benchmarking and identifying best performers, what's the most effective next step?
Learning is good, but action is better. The next step is to take those best practices learned and implement changes back at the team's own site to try and achieve similar results.
Adapt and implement what you learned. Question 92 asks for the best way to determine if a QI initiative was actually successful.
Success is measured against goals. You determine success by comparing the outcomes achieved with the pre-established goals or targets set at the beginning of the initiative.
Did you meet your goals? Question 111. A PI team is moving very slowly. What's the most important factor for the Quality Council to assess?
If a team is struggling, the first thing to look at is often its makeup. Assessing the composition of the team, do they have the right skills, knowledge, representation, and authority is crucial.
Check if the right people are on the bus. Question 146 identifies a missing key step in a critical care QI team's process focused on ventilator-associated pneumonia. They analyzed data and implemented a bundle but missed something.
Critical care improvements often require buy-in from multiple groups. A missing step might be collaboration with medical staff leadership and potentially referring physicians, like family practice, if involved pre-post ICU, to ensure support and consistent practice.
We need broader collaboration. Question 151 involves interpreting results of a patient education study showing improvement but not statistical significance.
If results show improvement, but the p-value is greater than 0.05, not statistically significant, it means that while there was a positive trend, you can't confidently rule out the possibility that the observed improvement was due to chance rather than the intervention itself, given the sample size and variability. It doesn't prove the intervention failed, but doesn't provide strong evidence it worked either.
Positive trend, but could be chance. Question 154. Pharmacy and nursing are conflicting over medication error reporting. What's the quality professional's best role?
The quality professional shouldn't take sides or dictate solutions initially. Their best role is often to act as a neutral facilitator, bringing the two groups together to discuss the issues openly, identify root causes of the conflict, and help them collaboratively find solutions.
Facilitate the conversation. Question 162 asks for essential components of an effective QI plan.
A good plan needs structure, clear goals, defined standards or targets, specific measures to track progress, thresholds for action, and a way to track and report results.
Goals, standards, measures, thresholds, results. The core elements. Question 175 asks, what is not typically a critical first step when implementing a new program?
When implementing something new, it's usually wise to start small to test and refine it. Therefore, system-wide implementation right from the start is often not a critical first step. A pilot test is usually preferred.
Pilot test first, don't go big bang usually. Question 176 asks for the most useful data element for evaluating a fall prevention program's success.
While tracking fall rates is the ultimate outcome, understanding why falls happen or are prevented often comes back to the initial assessment. The nursing assessment of fall risk factors is incredibly useful data for evaluating if the program is identifying the right patients and if interventions match the risks.
The initial assessment quality is key. Question 189 asks about characteristics of an ideal pilot unit for a new fall prevention program.
You want a unit where you can really test the program. Ideal characteristics include a high-risk patient population, so you have falls to prevent, possibly a high current fall rate, staff willing to participate, and strong unit leadership to champion the pilot.
High risk, high rate, willing staff, good leader, good pilot criteria. Question 194. A quality council is starting to develop a fall prevention program. What's the logical initial step?
Before designing a new program, you need to understand the current situation. The first step should be an evaluation of the current program's findings, if one exists, or current fall data and risk factors within the organization.
Understand the current state first. Question 203. What's the recommended first step in using reliability science principles to improve patient safety culture?
You can't apply what you don't understand. The first step is usually to educate yourself and key stakeholders about the principles of high reliability and how they apply to healthcare.
Learn about it first. Question 205. How best to gain staff support for new infection control procedures?
Staff are more likely to adopt new procedures if they understand the why. Linking the new procedures directly to patient risk reduction and improved outcomes is usually the most effective way to gain buy-in.
Explain how it helps patients. Question 208 asks about the ideal role of a senior leader participating in a collaborative quality improvement team.
The senior leader brings crucial resources. Their ideal role is often providing authority to make decisions and the ability to allocate necessary resources, time, money, staff, to support the team's work.
Provide authority and resources. Question 214. After implementing a new plan or process, what's the recommended next step according to QI principles?
Implementation isn't the end. Continuous improvement means you need to constantly evaluate the results, the check and act steps of PDCA, to see if the plan is working as intended and make adjustments.
Check and act. Keep evaluating. Question 216 identifies a potential weakness in QI implementation. Compartmentalization. What does that mean?
Compartmentalization means QMQI activities are isolated within a specific department or team and aren't integrated across the organization or linked to overall strategic goals. This limits their impact and sustainability.
Working in silos is a weakness. Question 226 asks about essential steps for a successful emergency department improvement team.
ED improvement is complex. Essential steps usually include getting strong administrative and medical leadership support, involving multidisciplinary frontline staff, nurses, techs, docs, clerks, setting clear goals, and using data to drive decisions.
Leadership, multidisciplinary team, goals, data. Sounds familiar. Question 242. A new quality management director starts. What's one of the first key issues they should evaluate?
To understand the lay of the land, the new director should assess the existing quality culture, particularly the level of leadership knowledge and involvement in quality initiatives. Is quality truly a priority from the top?
Gauge leadership engagement first. Question 244 asks, what is not typically considered part of continuous improvement through teamwork? Options might involve team processes like planning, doing, checking, acting, but also informing.
While communication is vital, simply informing others might be considered a passive step compared to the active engagement involved in the core teamwork cycles of planning, implementing, and evaluating improvements together. So, informing might be the intended outlier.
Passive informing versus active teamwork. Question 249 asks about the main role of a physician champion for a new antibiotic utilization plan based on the provided options. Self-correction. Outline notes the provided option might be narrowly focused.
While a champion's role is broad, education, advocacy, if the options are limited and one is about detailing physicians who failed to comply, that specific accountability or peer influence aspect might be presented as a key function in some contexts, even if it's not the only role.
Okay, focusing on the peer influence aspect in this specific context. Question 274 asks, what best describes the successful outcome of the quality improvement process?
Ultimately, the goal of improving quality in healthcare should lead to better outcomes and experiences for the end user. Therefore, customer satisfaction, with customer broadly, including patients, is a key indicator of successful QI.
Happy customers, successful QI. Question 279. What's essential when selecting new QI software?
To ensure the software is actually useful and gets adopted, it's essential to get input from all potential users during the selection process. Their needs and workflow should drive the choice.
Involve the end users. Question 305 states that performance improvement of a process should primarily depend on what?
You can't know if you've improved unless you know where you started. Performance improvement efforts should be guided by baseline data that shows the current level of performance before interventions begin.
Need that baseline measurement. Question 331. A fall prevention intervention was implemented, but there's no noticeable change in fall rates. What's the best next action?
If the intervention isn't working, don't just abandon it immediately. First, evaluate staff understanding and perception of the intervention. Are they implementing it correctly? Do they believe it works? Maybe the problem is implementation fidelity, not the intervention itself.
Check implementation before bitching the plan. Question 336 describes re-engineering QI processes for newly merged facilities. What stage of a process does this represent?
Re-engineering implies fundamentally rethinking and redesigning how work is done. This represents the planning redesigning phase of process management.
Redesigning the process. Okay, final major theme. Accreditation and regulatory compliance. Question 80 asks for examples of hospital external customers.
External customers are entities outside the hospital that rely on or regulate it. Examples include accreditation agencies like Joint Commission, insurance company suppliers, and even an outpatient using specific hospital services.
Lots of external stakeholders.
Yeah.
Question 113 asks for the definition of credentialing.
Credentialing is the process of obtaining, verifying, and assessing a practitioner's qualifications to provide patient care services. It confirms their license, education, training, and competence.
Verifying the qualifications. Question 118. A surgeon wants to do a specialized procedure but lacks privileges for it. What document is most helpful in this situation?
The rules governing who can do what procedures are outlined in the medical staff, bylaws, rules, and regulations. That's the document that defines a privileging process and requirements.
Check the medical staff bylaws. Question 121 asks for a key requirement for a root cause analysis, RCA, to be effective in preventing future errors.
An RCA needs diverse perspectives to uncover system issues. A key requirement is utilizing a multidisciplinary team involving people from different roles and areas related to the event.
Multidisciplinary team for RCA. Question 125 asks who creates the list of hazardous materials that require safety data sheets within a facility?
While regulations set requirements, the specific inventory list of hazardous materials present is compiled by individual facilities based on what they actually use and store.
Each facility manages its own inventory list. Question 229. What's the most important aspect to consider when hiring an accreditation consultant?
You want someone with a proven track record. Checking their references, talking to other organizations they've worked with, is probably the most important step in vetting a consultant.
Check references. Good advice. Question 239 asks for the most effective way to improve poor compliance with standard precautions, like hand hygiene.
If compliance is poor, simply reminding people might not be enough. Often you need to review and revise the policies and procedures to ensure they are clear, practical, and well communicated, and then follow up with education and monitoring. Sometimes the process itself is a barrier.
Review the policy and process first. Question 243 asks what the practitioner clinical privileging process actually grants.
Privileging grants permission for a practitioner to provide specific patient care services within the organization, based on their demonstrated competence. It defines their scope of practice within that facility.
Permission to practice specific services. Question 256 asks again for the definition of the practitioner credentialing process.
Credentialing is the verification of a practitioner's right and competency to provide care, confirming their license, training, experience, etc.
Verification of competency. Question 262 asks about the purpose of national databases related to clinical privileges and liability claims, like the National Practitioner Data Bank.
These databases exist to enable healthcare organizations to access crucial data about practitioners during the credentialing and privileging process, helping them identify potential concerns related to past performance or disciplinary actions.
Central database for background checks. Question 273 asks about the usefulness of incorporating annual performance data into accreditation scoring.
Using annual performance data allows for a continuous evaluation of compliance with standards rather than just relying on point-in-time surveys. It promotes ongoing readiness.
Continuous evaluation. Question 280 asks, what is not typically required for an organization-wide quality management program? Options might include policies, data collection, leadership oversight, and specific software.
While software can be helpful, having alternative QM software products available isn't a fundamental requirement for the program itself. The core requirements relate to structure, process, leadership, and data, not specific vendor products.
The program structure matters more than the specific software brand. Question 284. Reviewing medical record equipment like EHR systems and content focuses on which aspect of care quality, structure, process, outcome.
The medical record system, forms, and how documentation is organized are considered part of the structure of care, the resources and systems available to support care delivery.
The record system is structure. Question 313 states that clinical privileging depends on what?
The entire privileging process, how decisions are made, criteria used, appeal mechanisms, depends on the process encoded in the medical staff bylaws and associated documents.
It's all defined in the bylaws. And question 320 asks for a reliable source to determine a practitioner's current competency.
While background checks are important, assessing current competency often relies on ongoing professional practice evaluation, OPPE, and focused professional practice evaluation, FPPE data, often summarized in a practitioner's profile or performance report within the organization.
Look at their current performance profile. Okay, just a few more themes. Ethical, legal, statistical concepts, benchmarking, and patient-centered care. Let's hit ethical and legal quickly. Question 31 defines psychic externalities based on the options provided.
This is an economics term. Based on typical options, it likely refers to the external costs and benefits associated with caring about other people's well-being or utility, even if you aren't directly affected.
Caring about others' well-being. Question 130 presents a scenario. A surgical towel is left inside a patient. What legal doctrine most likely applies?
That situation where the event itself implies negligence, because it wouldn't normally happen without it, strongly suggests the doctrine of res ipsa loquitur, meaning the thing speaks for itself.
Res ipsa loquitur. Question 161 asks about the importance of organizational liability and healthcare quality.
Holding the organization responsible, organizational liability, is important because it incentivizes the organization itself to identify care deficiencies and implement system-wide improvements, rather than just focusing on individual blame.
Drives organizational accountability. Question 267 asks, what is not typically included in both utilization management, UM, and quality management, QM plans?
Both UM and QM involve processes and data, but the specific process for appealing treatment denials is primarily a function of utilization management, dealing with coverage decisions, rather than a core component of most general QM plans.
Appeal process is more UM specific. Question 281. A quality officer needs to report ethics concerns. What's the best communication strategy?
Reporting ethics concerns requires careful handling. A good strategy involves clearly reforming or outlining the issues, basing concerns on objective research or evidence, and making constructive recommendations for addressing the ethical lapse.
Be objective, evidence-based, and solution-focused. Okay, quick stats concepts. Question 98 asks for an example of a nominal variable.
Nominal variables are categories with no inherent order. Religion is a classic example. Other examples include gender or race.
Categories without order? Question 106 gives a population of 1,200 and a sampling interval of 10 for systematic sampling. What's the sample size?
If you sample every 10th person from 1,200, the sample size is 1,200 divided by 10, which equals 120.
Simple division. Question 122 asks for the most common statistical tests used to evaluate the reliability, internal consistency of a survey questionnaire.
The standard measure for internal consistency reliability of a scale or survey is Cronbach's alpha.
Cronbach's alpha for survey reliability. Question 124 provides data on amputation rates from 2 hospital samples, details omitted, and asks for a conclusion. Let's assume sample A has a higher standard deviation.
If sample A has a higher standard deviation in amputation rates than sample B, the primary conclusion is that sample A has more variability in its rates. The results are less consistent.
Higher standard deviation means more variability. Question 178 asks for the definition of the range in data. Self-correction. Outline notes incomplete definition.
The range is the simplest measure of spread. It's the difference between the highest and lowest values in a data set. The provided option might just say equal to the highest recorded data, which is incomplete, but perhaps the intended key part in a flawed question. The full definition is highest minus lowest.
Highest minus lowest. Question 210 asks for an example that is not binary data. Binary data has only 2 categories. Options might include yes, no, male, female, improved, not improved, degree of BP reduction.
Yes, no. Male, female, improved, not improved are all binary. The degree of blood pressure reduction, for example, 10 mmHg, Hg, 15 mmHg, Hg, is a continuous or at least interval ratio variable, not binary. So D is not binary.
Degree of change isn't just 2 options. Question 236 involves calculating N, mean, range, mode, average, mean again, and median from C-section data, data omitted.
Right, this would involve applying the standard definitions. N is the count of data points. Mean is the sum divided by n, range is max, minus min, mode is most frequent, median is the middle value when sorted.
Basic descriptive stats calculations. And question 301 asks what the p-value determines in a clinical trial.
The p-value represents the probability of observing the study results, or results more extreme, if the null hypothesis were actually true. A small p-value suggests the observed results are unlikely if there's truly no effect.
Probability results are due to chance if there's no real effect. Okay, benchmarking briefly. Question 56 says benchmarking is based on identifying what?
Benchmarking is fundamentally based on identifying best practices, finding out who does something best, and learning from them.
Identifying best practices. Question 95 describes setting targets by selecting top performance levels. What's this called?
That process of setting goals based on the best performance seen elsewhere is benchmarking.
Benchmarking. Question 298 involves comparing current practice with the best facility.
That's benchmarking.
And question 298 is comparing outcomes with similar hospitals.
Again, benchmarking. Seems clear.
Definitely a recurring theme. Okay, final stretch. Patient-centered care and related concepts. Question 129 contrasts quality leadership with management by results, stating quality leadership starts where?
Quality leadership, particularly in the TQM philosophy, starts with understanding and focusing on customer needs and expectations.
Start with the customer. Question 169 asks for the interpretation of common cause variation on a control chart.
Common cause variation represents the inherent expected fluctuations in a stable process. If the results are similar and stay within the control limits, it's generally considered stable and not concerning. You don't need to react to each minor up or down.
Normal variation within limits isn't alarming. Question 188 describes failure-free operation over time. What quality dimension is this?
Failure-free operation over a period of time defines reliability.
Reliability. Question 202 asks for the definition of a measure of the quality of attainment in meeting objectives.
That definition points to effectiveness. Are you achieving the goals you set out to achieve?
Effectiveness is meeting objectives. Question 211 defines appropriateness of care.
Appropriateness means doing the right things, providing care that is indicated, evidence-based, and suitable for the patient's condition, avoiding overuse and underuse.
Doing the right thing for the patient. Question 213 suggests two quality dimensions should be incorporated into all QM activities. Which two?
While many dimensions are important, effectiveness, doing the right thing, and respect, or patient-centeredness, are often highlighted as fundamental dimensions that should permeate all quality efforts.
Effectiveness and respect, core values. Question 220 asks for important criteria for evaluating a measure of quality itself.
A good quality measure needs to be trustworthy. Key criteria include its scientific validity, does it measure what it claims, and reliability, does it measure consistently.
Validity and reliability of the measure itself. Question 221 describes the capacity of a migraine prophylactic to improve health status under ideal conditions, like a clinical trial. What term describes this?
The ability of an intervention to work under ideal conditions is its efficacy. Effectiveness refers to how well it works in real-world practice.
Efficacy is ideal, effectiveness is real world. Question 231 asks which dimension of quality is particularly dependent on evaluation by recipients or observers.
Dimensions like technical skill might be judged by experts, but respect and caring are dimensions primarily evaluated through the perceptions of patients and their families.
Respect is judged by the recipient. Question 238 mentions a difficulty in establishing outpatient QMQI that focuses purely on outcomes. What's a key reason?
In the outpatient setting, the patient still has significant control over their environment, behaviors, and adherence between visits, making it harder to directly attribute outcomes solely to the care provided by the clinic compared to an inpatient setting.
Patient factors play a bigger role outside the hospital. Question 252 asks what is not a basic component of managed care. Options likely include provider networks, financial incentives, broad choice of providers.
Managed care often involves selected provider networks and utilization controls to manage costs. Therefore, a broad, unrestricted choice of providers is typically not a characteristic of most managed care models.
Managed care often limits provider choice. Question 264 asks what most influences patients' perception of quality in ambulatory outpatient care.
While technical skill matters, patient perception in ambulatory settings is often most strongly influenced by interactions with staff, having caring staff and physicians, is frequently cited as paramount.
Caring interactions matter hugely. Question 272 notes human-generated data might be less independent than machine data. Why?
Humans are complex. Human behavior changes gradually, is susceptible to momentum, doing things the same way, is capable of cognition, thinking and adapting, and is generally more likely to err than automated systems. This makes human-generated data potentially less consistent or objective.
People aren't machines. Question 275 lists important issues when negotiating contracts with health plans.
Key negotiation points typically include reimbursement rates, requirements for physician board certification, data reporting requirements, and processes for credentialing.
Money, credentials, data requirements, key contract points. Question 287 refers to the IOM's aims for improving healthcare from crossing the quality chasm, which is not one of those aims. Safe, effective, patient-centered, timely, efficient, equitable, high profit.
The 6 IOM aims are safe, effective, patient-centered, timely, efficient, and equitable. Steep. High profit is not one of the stated aims for healthcare improvement from that report.
Profit wasn't an IOM aim. Question 288 asks which attribute does not characterize quality healthcare services. Options might include accessibility, effectiveness, efficiency, excess staff.
Accessibility, effectiveness, and efficiency are all positive attributes of quality. Having excess staff might actually indicate inefficiency, so it doesn't characterize quality.
Excess staff isn't quality. Question 290 asks for an effective action to establish a safety culture.
Creating psychological safety is key. Adopting an anonymous, non-punitive reporting system encourages staff to report errors and near misses without fear, which is foundational for learning and improvement.
Anonymous free reporting. Question 296 asks again for the definition of a measure of the quality of attainment in meeting objectives.
As before, this defines effectiveness.
Effectiveness again. Question 299 asks about the focus of clinical practice guidelines, CPGs.
CPGs aim to translate evidence into recommendations to minimize undesirable procedure variability and promote evidence-based care.
Reduce variation with evidence. Question 300 involves calculating a percentage profit increment. Details omitted.
This would be a standard percentage change calculation. New profit, old profit, 100%.
Basic percentage calculation. Question 304 asks about the purpose of a quick response team. QRT, or Rapid Response Team, RRT?
The purpose is to provide an immediate response by a specialized team to patients showing signs of abrupt clinical deterioration, aiming to intervene early and prevent codes or ICU transfers.
Early intervention for declining patients. Question 310 asks how a medication error is generally regarded in a legal or safety context.
While not always leading to lawsuits, a medication error that causes harm because care fell below the expected standard can be regarded as negligence.
Can be seen as negligence. Question 319 describes a blood pressure measurement technique that yields significantly different readings each time on the same patient. How would you describe this measurement?
If the measurement gives widely different results under the same conditions, it is unreliable. It lacks consistency.
Unreliable measurement. Question 321 asks what is not typically considered important when developing practice guidelines. Options: evidence, expert consensus, patient expectation, cost effectiveness.
Evidence, expert opinion, and cost are usually considered. While patient preferences are important when applying guidelines, patient expectation in isolation isn't usually a primary driver for the initial development of the evidence-based guideline content itself.
Guideline development focuses on evidence more than initial expectation. Question 324 asks what questions the balanced scorecard helps answer.
The balanced scorecard looks at performance from multiple perspectives: financial, customer, internal process, learning growth. It helps answer questions like, how are we doing across these areas, and are we there yet in terms of strategic goals?
Multi-perspective performance view. Question 328 describes an intervention that occurs during the actual process of clinical care. What type of intervention is this?
Interventions that happen while care is being delivered are called concurrent reviews or interventions, as opposed to retrospective or prospective.
Happening at the same time.
Yeah.
Question 329 asks about conformance costs in quality management.
Conformance costs are costs incurred related to preventing errors, things like training, quality planning, process controls, inspection. They are the costs of making sure things are done right.
Cost to prevent problems. Question 330 asks which quality dimension is actualized by eliminating waste.
Eliminating waste of time, resources, steps directly improves efficiency.
Efficiency means less waste. Question 333. A surgeon has a high wound infection rate. What data is most useful for investigation?
Prophylactic antibiotics are crucial for preventing surgical site infections. Investigating the surgeons or their team's use of prophylactic antibiotics, timing, choice, documentation would be a highly relevant starting point.
Check the antibiotic use. And finally, question 334 asks about the most important consideration for long-term strategic planning.
Effective long-term strategy requires looking both inward and outward. It needs careful consideration of the organization's internal potentials, strengths, weaknesses, and the external environment, opportunities, threats. A SWOT-type analysis.
Internal strengths and external environment. Okay, wow. That was a comprehensive run-through of a lot of key concepts via those MCQs.
It really covers the breadth of healthcare quality, doesn't it? From high-level principles down to specific tools and regulations.
Absolutely. We hope this deep dive, using that question and answer format, gave you a solid, condensed review and maybe highlighted some areas you want to explore further. Understanding these principles is just so vital for anyone in or around healthcare.
Definitely. Reflect on which questions or themes felt more challenging. That's often a good signpost for where to focus future learning.
And to leave you with something to think about. Considering everything we just covered, QI, safety, data, leadership, operations, what single principle or concept do you believe has the most significant impact on the actual quality of care patients receive day to day?
That's a tough one. Lots of contenders.
It is. Something for you, our listeners, to mull over. Thanks for diving deep with us today. Stay curious.